So our first speaker of the morning is Dr. Mark Roberts, and he's going to talk about Frailsafe. Mark is a physician on the Craigavon and Armagh sites and spends a lot of his time and has a great interest in working in MAU. Mark.
Good morning, everybody. I don't use the word I guarantee very often in my day-to-day work, but I guarantee everybody in this room either knows somebody or is related to somebody who could potentially benefit from this project. So I hope you'll get a flavour of that by the end of the talk. So what we're going to talk about is improving the care of frail older people in the medical admissions unit. For those of you who don't know how the hospital sort of set up for emergency unscheduled care, we would probably be the main receiving unit for non-surgical, non-trauma patients who need to come into hospital. So you can imagine we're high turnover, quite high risk in terms of clinical information, communication and leadership is a really important part of what we do. And last year in September, we were chosen as one of only 12 sites across the whole of the UK to take part in this national quality improvement project called Frailsafe. And it's really about this thing called a safety checklist, which is only one sheet of A4 and prompting us to think about some key evidence-based interventions that we know that often can reduce harm and hopefully provide patient benefit. It's designed to trigger an interaction. I've phrased that clumsily. It's not really specifically between a senior doctor and a junior member of staff, it's between the whole multidisciplinary team. And it's about using this concept that I like to describe as team brilliance. Team brilliance is much more important than individual brilliance. My mother thinks I'm brilliant, but I'm pretty sure most people don't, other than that. But individual brilliance is very tiring. You have to always feel like you've got to be right. You've always got to have the right answer. That's not the way health services should or can operate, in my view. I think it's always about a team being brilliant. And I think I'm very much privileged to be part of a brilliant team. So I want to spend a bit of time just on this checklist for a moment, if I may just focus you on it. So the idea is that we're identifying people who are frail as either confused, live in a care home, or have reduced mobility. So that might be they use a walking stick or a wheelchair frame in their day-to-day life. So we consider them frail for the purposes of this project. And then it's prompting us to think about some key things, some assessments around, do we think the person might have a delirium, which is a really important issue? Do they possibly have an underlying dementia nobody's diagnosed, or that is diagnosed and we need to make allowances for that? Do we think about mobility, falls? You can all read, so I'm not going to rattle through each component part. Resuscitation is a really important thing because you can get older people who absolutely should be escalated to intensive care and the very highest level of care that medical science can offer. And then there are a lot of people who, frankly, if we go down that route, we're missing the opportunity to give them a compassionate and dignified death. So resuscitation is a really important thing to consider. And the thing I want to point out to anybody who's sort of, skeptical about checklists, this isn't a challenge to anybody. This isn't a challenge to my intellect or my team's intellect. This is just something to prompt us about the most critical steps that we think might be able to help care. And what we're trying to do is improve the consistency and the reliability of what we're doing. So the other elements are about equipment, thinking about intravenous cannulas, urinary catheters, do we need to keep bed rails up, and also medication. That's a huge area. And one of my interests, my other line of work is as a geriatrician, and I think we still live in a society and a health service where you get to your 60th birthday and we think you should accrue a new tablet every Christmas. So by the time you get to 80, you've got 20 tablets. Nobody's ever looked at it since 1974. And, a lot of people, unfortunately, are caught up in that trap. So you might say all of that's self-explanatory. Surely we should be doing that anyway. Well, I'm afraid it's not as simple as that. Good care isn't rocket science, but it's about connecting what we know with what we do. And I think studies all around the world have shown that actually very often what we think we're doing is not necessarily what we're actually doing. And this is what this is all about. So there's been a lot of good presentations to come, and there's been lots of good points made so far, but if there's one slide you take away from today, I'd really like it to be that one. It's about connecting what we know with what we do. So how did we get started? I think the most important thing whenever you're starting a project, and we really focused on this a lot, was start with the why. Why are you changing? I don't believe in change for change's sake. It has to be something to improve things. You've got to try and light up the staff's interest in this case. Why are we changing? What are we trying to achieve? We're trying to improve care for a very vulnerable group. So we had a steering group, which was members both within MAU and some key members outside of it to help give us direction, keep the momentum going, provide a bit of reflection, think about whether we need to revisit certain areas, like are we screening for delirium particularly well? Are we doing particularly well in terms of picking up on whether we're addressing resuscitation in the key post-take ward round on the morning after patients come in? And we had weekly meetings with them to keep the momentum going. I think that's really important. And I think the other key message is really start small, Small tests of change. You'll probably hear this a lot throughout the day or see it on the posters. Start small tests of change, see what you're learning, and then upscale it as you feel more confident. And for those of you like data, that's our weekly chart of how many we were doing. And you can see at the start, we were sort of fluctuating. One week we were doing fantastically well, and another week we were doing terribly. I think I was off that week. That's the reason. No, but joking apart, you can see there's huge fluctuations. But I think as things have gone on, I hope you can see that those peaks and troughs have started to even out. And we're just becoming a bit more, like I said, consistent, a bit more reliable in doing the checklists. Because not everybody in MAU needs that checklist, because not everybody in MAU is frail, but we're trying to target this group that benefits the most. So for those of you who like data, I'm going to give you data in a minute, but I'm going to embrace this. Let's talk about patient story, because I've got huge amounts of patient stories, and I think that talks to everybody in the room. So I'm going to tell you a true story. None of it is made up, and I'm not merging two stories together. Joan is a 75-year-old lady who came into us having been in hospital 10 days previously. She had nausea and was off her food for about 3 months. She was losing a bit of weight, and she came in under a different clinical team who were worried that she had an underlying cancer, because that would usually be one of the things we'd think about. And she'd had a lot of tests done, to be fair to that team. She'd been treated with some very fancy antibiotics because they thought she had a complicated water infection. And she went home after 10 days. And now she tells us she didn't feel any better. I don't know if that's true or not. And I'm not trying to pass judgment on another team in the same way I wouldn't want people to just make sloppy, lazy judgments on my care. But what she did come back in was because her nausea was ongoing. It was now really approaching 4 months. Now, on the post-take ward round, now that's not her, by the way. I should have pointed that out at the start, but she did consent to that photo. On the post-take ward round, in this sort of a setting, one of the things that the checklist prompted us to do was look at her medication. She was on 12 medication, 3 of which could cause nausea. And she'd been on this for a long time. Now, we stopped those, and we just said, press the pause button, let's not do anything else. 48 hours later was the first time in 4 months that she'd not had any nausea. So we let her home that afternoon, and we followed her up by telephone review, which is something else that we do in MAU, quite a lot of ambulatory care. And her nausea had stayed away. So we'd actually suggested to the previous team, maybe she doesn't need the camera test, but I don't want to step on anybody's toes. Maybe she may still have another cause for her nausea. But I think the key thing is she felt a lot better. Her appetite was returning. So there's a patient story. But if those of you like data, now, don't be bamboozled by this. I'll talk you through it. So delirium assessments, we started off at about 20% of people getting it. We had a bit of a good run, and then we dropped down, but we're averaging 40%. So is 40% excellent? No, it's not excellent, but it is better, and that's another key thing. And we're going to work on getting up to 60% and keep building that way. In terms of resuscitation, are we considering it? That's not to say people are or aren't for resuscitation. That's a different thing. That's very individual specific. And we involve the patient and the family in that decision. But in terms of have we actually considered it and whether it's an issue that we need to think about, you can see we're much more consistently doing that. For those of you who like hard metrics, if anybody's from performance, I'll do you now. Now, this isn't all due to the Frailsafe project. We've made changes in the way we run MAU in terms of the consultant supervision. We're a much more ward-based team than historically had been the case. But I think Frailsafe has contributed to the quality of some of this data. So you can see that red line is, I can't quite read it from here, but that's the over 65s transfers to other units. And you can see that's been dropping on a month-to-month basis. We're transferring fewer people out. And that's because we're getting more people home. And the reattendance percentages are not going up. So we're not just transferring people home and then they're coming back in 3 days later. I think that's improving. And probably the stat that I'm most pleased about, we tracked 180 people who were on the Frailsafe Proforma and followed their journey through. And out of the 180 that we tracked, 50% of those stayed in MAU and got home. And of those others, over 80% had no other moves after that. And I think this is a big issue across the industrialized world, that people are being bundled around hospitals, sometimes like tubs of butter. And we really, I think our bed management team have played a big part in supporting us on that. Because if you move frail older people around who are at risk of delirium, unless it's for their benefit, because they need to specifically go to coronary care or some specialist unit, you're really exacerbating things and making things worse for them. So I'm really proud of that stat. So my last slide is, where do we go from here? Well, the Frailsafe project, there's some of our staff there having a little look. We've invited, we walked that board around different parts, pharmacy, the nurses, the doctors and MAU, to try and get some feedback. We're trying to design a bit more of a bespoke sticker that's going to go into our post-take ward round. Maybe at some point it might be even in the medical admissions Clarkin Proforma or the nursing performance, trying to find a good place for it. If there's one wish I would do, I would say we'd have maybe been giving our staff who've been instrumental in this being successfully implemented or being successfully implemented a bit more feedback about how well it's going and what we're learning from it, because I think sometimes people haven't always seen the positive benefits for individual patients. I think maybe the patient story in those cases we should have been using more often, but it's a learning experience. And we've already had a number of inquiries, not only within the Southern Trust, but other trusts in the region asking us to partner with them. So we're very happy to share that in the spirit of collaboration. So I think that's everything I've got to say. Thank you very much for your attention. I'm happy to take questions later on.